Hello, my name is Rhonda Yantiss, and in this presentation, I'll be talking about small bowel biopsy interpretation with an emphasis on celiac disease and its differential diagnosis. I have no disclosures to report. And when thinking about duodenal biopsies, it's important to understand the indications for this procedure. Generally speaking, the folks who get a duodenal biopsy are those with diarrhea, iron deficiency anemia, abdominal pain or bloating, a family history or suggestive serologies of celiac disease, inflammatory bowel disease, either ulcerative colitis or Crohn's disease, immunodeficiency, and gastrointestinal hemorrhage. Of these, the first few indications are really questions pointing towards the possibility of celiac disease. And so our role is to inform the clinician about the likelihood of this underlying disorder. Duodenal biopsies are prone to some challenges in interpretation for a variety of clinical, technical, and interpretive reasons. Clinical indications, often we don't get any history. We might rule out a sprue or abdominal pain, and that's pretty much it. Technical problems can be related to poor tissue orientation, small biopsies, or too few tissue fragments that are not reflective of the findings throughout the proximal small intestine, and then the overlap between normal findings and those that might suggest a disease. There's also an extensive differential diagnosis for what seem to be nonspecific inflammatory changes, such as increased intraepithelial lymphocytes. Now, in the normal duodenum, we expect the villus to crypt ratio to be somewhere around 3 to 5 to 1, meaning that the villi stick up about 3 to 5 times as high as the crypts dive down into the lamina propria. We expect to see easily identifiable goblet cells and Panna cells scattered throughout the deeper crypt region, and it's okay to see 1 or 2 mitotic figures in a crypt. The normal duodenal lamina propria is home to the gut-associated lymphoid tissue, so we normally expect to see plenty of lymphocytes, plasma cells, and macrophages throughout the lamina propria. It's also frequent to see scattered eosinophils. Don't worry about that as long as they're not clustering or not located in the epithelium. And the same is true for the sporadic or occasional neutrophil. As long as they're not in the epithelium or associated with epithelial injury, don't give them too much concern. Now, one problem with duodenal biopsy interpretation is that it's easy. Hello, my name is Rhonda Yantiss, and in this presentation, I'll be talking about ischemic enterocolitis. I have no conflicts of interest to report. When we think about ischemic colitis, it's helpful to think in terms of large vessel occlusion versus non-occlusive ischemia. Large vessel occlusion usually occurs as a result of mechanical occlusion or a vascular occlusion of a large vessel due to thrombosis and embolus or large vessel vasculitis. Most of these entities are going to result in an irreversible injury to the bowel that results in a surgical resection. Non-occlusive ischemia occurs due to a variety of different factors: decreased splenic blood flow, increased blood viscosity, hypovolemia, sick patients, small vessel vasculitis, some medications, and infections. And the thing with the non-occlusive ischemia is that in many patients, multiple factors may combine to contribute to the picture of ischemic enterocolitis. In some patients, the injury is reversible and the patient can be treated symptomatically. In others, a biopsy may be required to confirm the diagnosis. And in severe cases, these injuries may lead to surgical resection. So for the most part, non-occlusive ischemia is the kind of thing you might encounter on a biopsy, whereas large vessel occlusive diseases are going to be encountered in resection specimens. When you evaluate a resection specimen, it can be helpful. There are some clues that can be helpful in pointing to a specific different diagnosis. When you have a resection specimen that is big and boggy and edematous and red with ulcers, that is usually going to reflect a venous outflow obstruction. What happens is there is a failure for the venous blood to clear from the bowel, and there's a back pressure and hemorrhage out into the interstitium and the connective tissues of the wall. So what you'll end up seeing is a completely viable or near normal mucosa that does not look ischemic, with tremendous hemorrhage and congestion in all layers of the wall. Arterial side events look a little different. The segment of affected bowel may show a sharp demarcation between the area affected by ischemia and the more viable regions. And histologically, this is an inside-out phenomenon with a... Hello, my name is Rhonda Yantiss, and in this presentation, I'll be talking about the classification of appendiceal neoplasms with particular emphasis on appendiceal mucinous neoplasia and some of its mimics, both neoplastic and non-neoplastic. I have no conflicts of interest to report. So in this presentation, what I'd like to do is help you develop a practical and relevant approach to appendiceal neoplasms that provides valuable information to clinicians and is prognostically accurate. So what we're going to do is talk about the biology and nomenclature of mucinous tumors in a variety of different situations, those confined to the appendix, those that have spread to the peritoneum, and those in which it's not clear to us what the natural history of the lesion might be. And to do this, I'm going to have to deviate from the current WHO classification, but I'll warn you ahead of time, and I apologize in advance. In the end of the presentation, we'll also spend a little bit of time talking about some of the other appendiceal neoplasms that can be mistaken for a mucinous tumor, as well as some potential mimics of appendiceal mucinous neoplasia. So first, let's start on the situation of the appendix in a patient that doesn't have any other disease beyond the right lower quadrant. So here's a case. We have an incidental finding in an appendectomy specimen from an older female. The peritoneum is free of disease at the time of surgery. The entire appendix was submitted for histologic evaluation, and one representative section is depicted here. You can see a circumferential proliferation of mucinous epithelium, mostly supported by some amount of lamina propria, although it's probably decreased. We can see the muscularis mucosae even at this magnification, and it appears to be intact. The lymphoid tissue is somewhat decreased compared to the normal, and we can see clear lines of separation between the muscularis mucosae, the submucosa, and the muscularis propria. So, what is the best term for this lesion? And I'll give you two choices: mucinous adenoma or low-grade appendiceal mucinous neoplasm. Now, before you answer that question, I'd like to pose this question. What is the likelihood of peritoneal recurrence for this completely resected lesion confined to the appendix? Is it close to 0? Is it close to 100%? Or is it somewhere in the middle? Well, I hope that most of you said that it's nearly 0, because it is 0%. Now, if we were in the naming business, what kind of name, or what would you call an epithelial